Okay, I'm still missing some people. Okay, I was informed late last week, like Thursday, that the university has discontinued the use of Blackboard Collaborate right in the middle of the summer, and is now using Zoom as the virtual classroom. I took a chance today to see, it was supposed to end on July 1st. Since it was a holiday weekend, I thought I'd take a stab at it to see if Blackboard was still working for today, and obviously it is. I am recording this. I have talked to Distance Education to make sure that they download the recording just like they did of all the other lectures and place it in your content area in case Blackboard goes away before you take your exam this week. Zoom is fairly easy to operate. I will, although I see the link there, I need to check it before I've been sending out invitations. And you click on the link and it brings you up, and it operates pretty much like this platform. They did not explain why they wanted to change it, nor the timing. So I did not want to kind of freak folks out by changing it. I'm really happy that I was able to get into it tonight. And by changing it like over the weekend, since we had such short notice. But know that regardless, you'll have the recording available to you if for some reason we lose access to it before the end of the week. Any questions about that? Okay. Okay, let's see, let's get through the anatomy. And so we've talked about respiration and the respiratory system functioning as a power supply to set our vocal, hello? Is there a question? Okay, to set the vocal folds into vibration, and the physics behind that we kind of studied was the fundamental frequency, the number of times, or the lowest or natural times that the vocal folds vibrated. And it's based on your gender and based on your age. For the articulatory system, we will then review and talk more about resonance. So the source spectrum So the vocal fold vibration and the harmonics, or the source spectrum, now will be flowing through your vocal tract. And your vocal tract consists of your throat, which we will refer to as your pharynx, your oral cavity, and your nasal cavity. And so articulation means how we're going to modify that source spectrum, the fundamental frequency and the harmonics, as it flows through the vocal tract. So these are a few of your articulators in your vocal tract. Your tongue, and we'll talk about the different parts of the tongue and the extrinsic and intrinsic muscles that make up your tongue. This is your oral cavity, your nasal cavity, your mandible, your maxilla, your velum, and your pharyngeal cavities, and there are 3 of those. Oops, and your lips. So the difference between humans and other mammals is that our vocal tract is situated at a right angle from our vertebrae. And so, and our sense organs, our eyes, our nose, our ears are oriented vertically, while our brain and spinal cord are oriented, your eyes, your nose, your ears are oriented horizontally on your cranium, and your brainstem and spinal cord are positioned vertically. Let's talk about the cavities that make up the vocal tract. Your pharyngeal cavity arises from supraglottally, so above your glottis, and ends at an arbitrary point in the back of your oral cavity. This is your oral cavity and your nasal cavity. The pharyngeal cavity ends also in an arbitrary point that differentiates between your nasal cavity and your pharyngeal cavity. Now, the area between, this is your velum, or your soft palate. And when your velum is lowered, it creates a port. And that port is called your velum pharyngeal port. We only open that port when we want to nasalize a production of speech, or when we want to articulate a sound that needs a nasalized sound. Otherwise, for all other phonemes or speech sounds, that port is closed. The velum rises against the wall of the nasopharynx. Sure. Okay, here we go. That is your velum. Your velum is also called your soft palate. Your uvula is also part of your velum, or the most inferior portion. And later we'll talk about or show you where your hard palate begins. So your hard palate is here. Okay, so you have your pharyngeal cavity, your oral cavity, and your nasal cavity. So this area. Any questions about the three subdivisions or major subdivisions of the vocal tract? And you're welcome to use your mic if you would like. Yes, it only leads into your pharynx and through your nares. Your nares, so the opening to your nose. Use nares, N-A-R-E-S. Okay. Okay, this is a better depiction. So you've got a better image of the separations of the pharyngeal cavity itself. And so we call that the feeding center also, particularly the oral pharynx, which is directly behind the oral cavity. Now, your hypopharynx can also be called your laryngopharynx because it functions right above your larynx, which is here. These are your vocal folds. And it also flows into your esophagus, which rests behind your trachea. And so this is your nasopharynx. And this little opening here is your eustachian tube. And we'll talk about that when we discuss parts of the ear. Again, there isn't a specific boundary between your nasopharynx and your oral pharynx or your oral pharynx and your hypopharynx or laryngopharynx. No, it's directly behind. So this would be a sagittal view that you're looking at. And so that is why your epiglottis is very important when you are eating or drinking. So your your epiglottis will bend over and cover this area to prevent food and liquids from entering your trachea. So when it folds over, food and liquids will flow into your esophagus where it should be. Any questions about the three anatomical divisions of the pharyngeal cavity or the pharynx? Okay, there are pharyngeal muscles that help to constrict or narrow your pharynx during swallowing and to narrow your pharynx during the modification of the source spectrum that's produced by your larynx. There are three constrictors. The most inferior constrictor is here. So let's see if I can. So this is your inferior constrictor. This would be your middle or medial constrictor. And this is your superior constrictor. And this, we're looking at a sagittal view or a lateral view. Now, if we were looking at a posterior view, this would be your superior constrictor. Your medial constrictor. And your inferior constrictor. Okay. So your inferior constrictor is the lowest and the strongest, and it arises from your cricoid cartilage of the larynx and then wraps around your entire pharynx, including your esophagus. More superiorly is your medial constrictor that arises from the horns of the hyoid bone and wraps around your pharynx. Your superior constrictor arises from your soft palate and sweeps around the sides of your nasal cavity. Okay. So there are 3 constrictor pharyngeal muscles. Your cricopharyngeus, and again, the name gives you an idea of where the muscle originates from and where it inserts. And so your cricopharyngeus is inferior to your inferior constrictor, and it arises also from your cricoid cartilage and encircles around your esophagus. This would be the posterior view. The last pharyngeal muscle that we'll talk about is your stylopharyngeus. It arises from your styloid bone or styloid process. Your styloid process is here. And your stylopharyngeus muscle is here. So you have, you're responsible for knowing 5 pharyngeal muscles: the cricopharyngeus, the stylopharyngeus, and the inferior, medial, and superior constrictors. Questions so far? Okay, let's look at the bone that forms the base of your skull. It is your sphenoid bone. It forms the roof of your pharyngeal and nasal cavities. So it forms the roof above the nasopharyngeal cavity and your nasal cavity. This is your sphenoid bone. And if we were to look at it anteriorly with imaging studies, it looks like bat wings. Your sphenoid bone has so this is the anterior view. This is the body. These are the greater wings. These are the lesser wings. It also has a process that's called the lateral pterygoid plate. And there is a medial pterygoid plate. Your orbital cavity rests within your greater wings. Or your sphenoid bone. And so this would be considered the roof. And so the roof would be the roof of your nasal cavity and the roof of your nasopharyngeal cavity. Questions? Yes. Here. So the roof, okay, so this area between the medial pterygoid plate, under it or inferior to it would be the nasal cavity and the nasopharyngeal cavity. So if we go back, we're looking at it. Well, we really can't see it there. So your nasal, I think I have the same color. So your nasal cavity would be here, right? And it's really, and your nasopharyngeal cavity would be running here to here. Does that give you a better orientation? for those of you that have sinus problems, you're very familiar with your sphenoid bone. It has sinuses, or open areas, that can form fluid and infection and give you and cause distress. Okay. Any more questions about the sphenoid bone?
I have a question.
Sure.
I'm looking at slide number 10, and I'm just wondering how the sphenoid bone fits. It kind of goes across the skull underneath where that, I don't know what that blue area is, the blue part of the skull is, but the sphenoid bone just kind of runs kind of left to right through the skull, or does it kind of curve so that it's kind of fitting with that blue front part of the skull? How does it exactly work in there?
Okay, so what you're looking at here would be the lateral part of the greater wings. This is your temporal bone of your skull. So your sphenoid bone is under your temporal lobe. And so what you're seeing here is the same, is the lateral portion of the greater wings. This is the side. So this would be your temporal bone here. Does that help?
So it's like are they kind of like plates that kind of sit atop one another? Is that a good way to think of it? The temporal bone and the sphenoid bone.
Okay, so your skull is comprised of several plates, correct, that are fused together.
Right.
Not as you get older after you're born. So the lateral portions of the greater wings would be fused, yes, to your temporal and parietal and, I'm sorry, your frontal. Let me point, I'm not using the pointer. Your frontal, parietal, and temporal plates of your skull. And so if I could...
Oh, sorry, go
ahead.
So if I was looking at that skull from an anterior view, and I was to remove the temporal bone, the blue, I think that's the temporal bone, would I be kind of looking dead on with the body in the middle of the skull with the body of the sphenoid bone?
Okay. I'm going to use,
did that question?
Let me use another color. Okay. This is your temporal bone. Okay, so that's right where your forehead is. But the body of your sphenoid bone is here. And so if you can take the tip of your nose, the body is right between your eyebrows. That's where the body is. This is your orbital cavity, and so this would be here.
So if I take my finger and I press it between my eyebrows, am I touching my sphenoid bone, or is that still my temporal bone.
No, you're touching your frontal. You're touching this.
The body of the
body. Mm-hmm.
So that's like when you wrinkle your furrow your brow. That furrow right behind it is the body of the sphenoid bone.
Yes.
Got it. Okay. Thank you.
Okay. You're welcome. Are there any other questions? Okay. All right, so let's take a look at your velum. And again, your velum, if you see it here, they have it colored in green. It is also called your soft palate. It is not made of bone. It's really made of a muscular flap that is attached to your hard palate. So it's attached here. If we were to look into the oral cavity and to look up superiorly, this would be your hard palate, which you see in blue. But the muscles here make up your velum. This is your tensor palatini muscle and your levator palatini muscle that make up the muscle flap of your velum. And this is your uvula. What you can see is kind of hanging in the back of your oral cavity. Your tensor palatini, when it contracts, it lifts the velum. The levator palatini muscle also elevates the velum. So when it contracts, the velum rises. And so those two muscles are responsible when they rise to close off that port, the velopharyngeal port here. So when the velopharyngeal port is closed, it closes off your nasal cavity. They both elevate the velum. And so when you're labeling those, the tensor veli palatini actually looks like a drapery valance. And then you have a secondary valance, which is your levator veli palatini here. Remember when we talked about muscles back in the preface, usually when a muscle moves a particular anatomical part in one direction, there is a muscle that returns it to its original resting spot. So there are two velar depressors. So if we want to bring your velum down to allow that spectrum of sound to flow through your nasal cavity, the palatopharyngeus and the palatoglossus are the two muscles that will open that airway, or the velopharyngeal port. This is your palatoglossus here. And this is your palatopharyngeus here. The area between is called your fossal pillars. And so let's see. This is really not a good. And so you're able to actually see your palatine tonsils. Let me make that another color. And so if you open your mouth and say ah, you'll see an arch that you'll see this arch here. But inferior to that arch and laterally, you'll see your tonsils. There are different types of tonsils, but the ones that we're familiar with are called your palatine tonsils. We'll talk about that in a minute. Any questions about your velum and the muscles that make up your velum? Okay. You actually have two sets of velums and then of tonsils, and then two other tonsils that are singular. And so the ones that we're pretty familiar with are our palatine tonsils here. So we can see those on the side of our pharynx, our oral pharynx when we open our mouth. What we cannot see are your tubal tonsils that are higher within the pharyngeal cavity. And your adenoid, which is probably the most superior area or of your nasopharyngeal cavity. The ones that we don't see that's right on the side of our tongue at the base is your lingual tonsil. That ring is called Waldeyer's ring. Tonsils are lymphatic tissue that help us contract. How can I put this? They help our body react to infection. No, typically when you have your tonsils taken out, it's your palatine tonsils. If you have a tonsillectomy and an adenoidectomy, then they'll take your adenoid. You know, that other than it being lymphatic, I don't know. And sometimes they call that a TNA. Let's take a peek and see what this says. They produce antibodies that help fight infection. So that's what most lymphatic tissue, that's the purpose of most lymphatic tissue. For some people, the adenoid tends to shrink during adolescence and maybe even disappear entirely for adults. Yes, my son had had his adenoid tonsils and a myringotomy tube placed in. Um, his adenoid was so large that they had to remove his two front teeth because they go in through the oral cavity to remove it, which I didn't know at the time. And so they came out to the waiting room and brought me his teeth and said they were his baby teeth. They needed to remove his teeth, and of course we needed braces later, but in order to remove it. And the minute he was born, when he was a baby, he was a mouth breather because it was so large it occluded his nasal cavity or his nasal pharyngeal area. Yeah, it's so funny. He's 24 now. That was just so. I was like, oh, they were like, here's his teeth. Here's his teeth. I was like, oh, okay. I did not expect that. But anyway, okay. Any questions about tonsils? Now, later, when we're talking about all of these cavities form as our resonators, right? They're going to help filter the source spectrum of sound produced by our larynx. And when a person has unusually large tonsils, particularly the tubal tonsils or the adenoid tonsils, and it occludes that passageway between the nasopharynx and the nasal cavity, that person sounds very hyponasal, meaning less nasal than usual, because the spectrum is not allowed to flow through the velopharyngeal port into the nasal cavity. And so they sound, very hyponasal instead of hypernasal. Oh yeah, with the with the Nashville Predators. Isn't that amazing? There must be a rite of passage to have your teeth missing. As a hockey player, I don't know. I'm not. I'm certainly not a bandwagon fan, but I learned more about hockey because they went to the playoffs than I have before. I used to be a football person, but now with concussions, I have issue with football. But I'm pretty much basketball now, tennis. Yeah. So, but hockey's just not one that, and I was busy Googling things as games were being played. So, okay. Yeah, I bet it's, yeah. I think I may do that just to have because the fans, hockey fans, are unlike really any other fans that I've seen. We were, for years, season ticket holders for the Titans, and Nashville's a young football city as far as I'm concerned, and so the crowd can be very finicky, but not for hockey. Okay. All right, let's take a look at the nasal cavity. So let's take a look at where we are. So this is our nasal pharynx, and what you're not seeing are the tubal tonsils and your adenoid, okay? This would be the velopharyngeal port, okay? This is your eustachian tube. We'll talk about that right now. This is your soft palate and your uvula. And this is your maxilla. And hard palate. This is a sagittal view. So if your tensor and levator palatini muscles are do not function properly, then you will not be able to close off the velopharyngeal port, and therefore the source spectrum of sound coming from your larynx through your pharynx will not only flow into your oral cavity, but will always flow into your nasal cavity, and you will nasalize every speech sound and pretty much render your speech unintelligible. And so if when you work with a child that has poor velopharyngeal competence, meaning poor ability to close off that port or to close off the nasopharynx by your tensor and veli palatini muscles raising it up and closing it off, then hopefully, if necessary, if it's not a neurological reason for the reason why the muscle is not moving the way it should, that there will be a way for an ENT to correct that. But if you don't have good velopharyngeal competence, then your speech is very unintelligible. Okay. Right. She'll need therapy, and hopefully by stretching it out, it still will perform well. And does she have any difficulty with feeding? Because sometimes, oh great. Okay, so with the stretching, it appears that the velum is able to close off the nasal cavity such that when the baby is feeding, for instance, milk, that milk is not going, up and through her nasal cavity. And because, as speech pathologists, because you have the knowledge of the anatomy and physiology of the head and neck, that is why individuals with swallowing disorders, or that is why swallowing disorders or dysphagia, or dysphagia, however you pronounce it, became part of the speech language pathology scope of practice, like in the late 80s, in the mid 80s, late 80s. And so that what the speech pathologist will do, given that the muscle is working, is to help that child remember or learn when to raise the velum for the pronunciation of a given phoneme. Okay, Susan, I'm sorry about that. Okay. So there are SLPs that deal strictly with feeding and feeding infants. It's usually when students graduate from graduate school and want pediatrics, everyone wants pediatric feeding. Okay. And there are many other reasons why you may have problems with swallowing with infants. Okay. Susan, this is your maxilla. This is your hard palate, your soft palate. Tubal tonsil, eustachian tube, nasopharynx, and where your adenoid typically would be. Not necessarily a weak nasopharynx, but it would be the velopharyngeal competence that you might want to that you might want to talk to your pediatrician about. Okay, so your heart palate will form the floor of your nasal cavity. So this is your nasal cavity. And the floor of your nasal cavity is your heart palate. Again, the roof of your nasal cavity is your sphenoid bone. Your nasal cavity has 3 turbinates, or scroll-like turbinates, and they're called conchas. And they're conchas in different parts of our body. But the first one, the most superior one, is your superior concha. This is your medial or middle concha. And this is your inferior concha. And so we're looking at a sagittal view, and this is just the lateral view of one side of your nasal cavity, because your nasal cavity is separated in the middle by your septum. And so we're looking at the right side of a person's nasal cavity, and the left side would look the same. Does that make sense? Okay. So let's talk about your heart palate. This is your maxilla bone. It runs right below your sphenoid bone. This is your cheekbone right here. The maxilla is right under your nose, nasal cavity. There, so right here. Okay. Your heart palate is formed by 2 bones. So your palatine bone, let's get another color. This is your palatine process here. This is your palatine bone here. And this is your premaxilla. All of that makes up your heart palate. Remember, this is your soft palate, or your velum. So what we would call, but we're not going to refer to that on the test, would be your upper jaw is your maxilla bone. And the premaxilla the palatine process and the palatine bone make up your hard palate. Now, in children, sometimes the bones, each plate, will not fuse, and there will be a cleft, an opening, and that's called a cleft palate, where those two bones or two processes do not fuse together. And so that presents a problem not only for speech, but definitely for feeding. Was there a question? That is your premaxilla. It's another part of the bone. This is your alveolar ridge. So if you would touch your two front teeth and pull your tongue back, that first ridge is the pink area. Now, if you pull it back further and it kind of drops off, it goes up, that's your premaxilla. Any questions about the hard palate? The red shows you the two palatine processes of the maxilla. So this is part of the palatine, the hard palate. You have a palatine process here, palatine process here. Below it, there's sutures that connect the palatine bone here and here. All of those areas make up the maxilla. Oh, that's not good. This is the maxilla, part of the maxilla bone, and that's your hard palate. This is the rest of your maxilla bone. And so what we've been talking about is what's on the inside here. Actually, if you take your tongue and move it back, you can actually feel that suture line. You should be able to feel the suture line there. Okay, so if there are any genital anomalies of the hard palate, speech pathologists will be involved because speech sounds will, again, be nasalized that shouldn't be nasalized because sound is allowed to enter, if there is a cleft, enter the nasal cavity via the oral cavity. Or there could be a person that has a very high arching, high palate that will change the resonance or the of their speech. Okay, so let's talk about dentition, your teeth. And it's a living structure that has several layers. The outermost layer is enamel. Under the enamel is dentin, and it's more of a bone-like substance. Dentin produces pulp, which is pretty central to within the tooth, and it has associated canals. And the part of the tooth that is within the gingiva or your gums is cementum, and the root of the tooth. So In the white is your enamel. This is your dentin. This is your pulp cavity in the red. Dentin produces pulp within the pulp cavity and canals there, or root canal. From here to here is your root. Here to here is the neck of your tooth, and this is the crown of your tooth. The outer edge of your root is cementum. Inside the pulp cavity, you have nerves and blood vessels. This is your gum tissue or your gingiva. And your tooth or teeth are either cemented into either your maxilla or your mandible bone. And I'm assuming that we're looking at the mandible since it's at the bottom. Questions about the parts of the inner parts of the tooth? So the first set of teeth are called your deciduous teeth. I've never heard of milk teeth before. Baby teeth, yes, but not milk teeth. So the first set are your deciduous, and they begin to fall out or come out between 6 years, maybe up to 16 or 17 years old, and your permanent teeth erupt through during that point. This would be your hard palate. Your hard palate is part of your mandible. This would be your maxilla bone or your lower jaw. And so in terms of your teeth, you have 2 central incisors. These are your central incisors of your maxilla. This is your central incisor of your mandible. Yes, the maxilla at the top, the mandible's at the bottom. Then you have lateral incisors. Next are your canines. Oh, let me go back. Canine. No, that's not what I had before. Canine, canine. You have 2 sets of premolars. First premolar. This is not working really well for me. Second premolar. First, second, first, second, first, second. And then eventually you will have 3 sets each of molars. First molar, second molar, third. First, second, third. And the same on the other side. For sure, the central incisors are one of the central and lateral incisors are important for placement and for occluding. And we'll talk about your ability to bite, for your bite to occlude There are some sounds where there needs to be good occlusion. So this would be a typical occlusion or bite. Your maxilla is just a little bit beyond your mandible, but there are 3 types of malocclusions where your upper and lower teeth do not close your oral cavity completely. The first is class 1 that you don't see, and that's just where typically your incisors, lateral and central incisors, are misaligned. Okay, they're not straight. Class 2 malocclusion, your maxilla overshoots your mandible. Class 3 is more serious. Your mandible protrudes beyond your maxilla. Typically, class 1 and class 2 can be corrected if it's not too severe orthodontia, but in some cases, with the class 3 malocclusion, you may have to actually break your mandible. Your mandible will be broken and reset. Any questions about the different classes of malocclusions? Yeah, it has. It really has. Okay, any question about dentition? Okay, let's look at the oral cavity. So again, this is your gingiva, here and here. This is your hard palate, soft palate, your palatine tonsils, your uvula, lips, your incisors, lateral and central, your tongue, premolars, and your molars. Now there are muscles that make up your cheeks and your lips. Your buccinator is here. Muscle is the major or the primary muscle of your cheeks. You also have further posteriorly is your masseter. This is your temporalis muscle. If you ever had a tension headache, temporalis is a little too tense. If you remember back in the respiration chapter, this is your sternocleidomastoid muscle there. And the muscles that make up your lips are called orbicularis oris here. So for this course, I'm only holding you responsible for those 5 muscles of the head and neck, or exterior muscles. Okay, no problem. In the pink, the fuchsia, is your sternocleidomastoid that inserts into your sternum, and this is your masseter, or masseter. This is your buccinator here. It makes up your cheeks. Your lips are made up by your orbicularis oris, and this is your temporalis that kind of fans out there. Questions? Okay, let's take a look at your tongue. Again, this is your maxilla, hard palate, soft palate or velum, your mandible, orbicularis oris, and we have your tongue. Your tongue is comprised of 4 intrinsic muscles, and there are also extrinsic muscles. The body of your tongue can be described as this is your tip of your tongue. The dorsum of your tongue, and the root in the back. Let's look at, that's a question on this particular picture. The blade would be really considered like the top of your tongue. And we're just kind of looking at the top of the dorsum. Do we need to know the different muscles? Yes, you do. So I doubt if I'll ask you, but this, you can call this the blade. Okay, let's take a look at the intrinsic muscles. The one that, well, this is again a sagittal view. This is a sagittal view. But this is a coronal view, so we'll go over this in a minute. Okay, so let's look at the sagittal view. You have the superior longitudinal muscle, and superior means top, so this is it here. Then part that runs here. Your transverse fibers run here. Your vertical fibers fan out here. And your inferior longitudinal muscle, this is really one of the few pictures that I can find, and you really only see it in a coronal view. This would be the inferior longitudinal muscle. This is the superior. Go back to this. So this is the superior here, and your vertical here, and your superior longitudinal here. It really isn't in this picture at all. So your inferior longitudinal muscle shortens your tongue. So when you want to pull your tongue in, that's your superior longitudinal muscle. It also curls your tip, curls the tip of your tongue. So if you want to place the tip of your tongue behind your teeth, that's your superior longitudinal muscle. Your inferior longitudinal muscle, when it contracts, it shortens your tongue also, but it's responsible for curling your tongue down. Your vertical fibers flatten your tongue, and the transverse fibers allow you to elongate, stick your tongue out, elongate, and narrow the tongue. It's the piece in the coronal.
Hi. So just to, maybe my question wasn't that clear. So in the right picture is the coronal view.
You're looking for the frenum?
Yeah. There's a piece between the two inferior longitudinal muscles that's kind of coming down in the middle. Is that the posterior frenum or frenula?
I'm not sure if that's
the right picture is the coronal, correct?
Here? I'm not sure. I'm not sure that's the frenum. I'm really not.
Okay.
Just because it's a coronal view, and a good way to identify the frenum would be a sagittal view. Does that make sense? So but that would be the general area, yes.
Okay.
But I don't know if that image, if that's what that is meant to be. It just looks too square for me.
Right. Okay.
Okay. Questions about intrinsic muscles? Okay, so those muscles make up the body of your tongue. This is another sagittal view. Your tip, body, root, maxilla. And this would be a coronal view of your tongue. So this would be your superior longitudinal, your vertical and transverse, and your inferior longitudinal muscle. Don't worry, I will not give you a picture of this one. to identify. It's just trying to give you an orientation, and this would be your hyoid bone and your mandible here, and your molars. Okay, there are 4 extrinsic muscles that are located on the outside of the body of your tongue. Your genioglossus, and I like this picture because the arrows give you an idea of what the function of the tongue when it contracts. So your genioglossus here, when it contracts, it pulls your tongue down into the trough of your oral cavity. Your styloglossus originates from the styloid process. And when it contracts, it pulls your tongue back and upward. Your hyoglossus when it contracts, pulls your tongue back and down. And your palatoglossus pulls your tongue back and upward. Questions about the extrinsic muscles of the tongue? It's another picture. Okay, this is your mandible. I will not ask you to identify the different parts of your mandible, but this is the body of your mandible. This is the ramus of the mandible and the angle of the mandible here. Again, the body of your mandible. Your mandible condyle and your coronoid process that helps to fit into the temporal bone that forms your temporomandibular joint. So your mandible is suspended from your temporal bone. The muscles on which slide? The previous slide, Susan? Yes, you'll need to know the intrinsic and extrinsic muscles of the tongue. I will not ask you to label the mandible, the mandibular parts, but you'll need to know where the mandible is, but not the specific parts of the mandible. Okay, there are ligaments that help to suspend your mandible bone from your temporal bone. There are 3, your lateral, your sphenomandibular, and your stylomandibular ligament. We'll not ask you to identify those. There are muscles that you'll need to know. The mandibular muscles are very important for your ability to open and widen your oral cavity and open your or separate your lips for speech production. We talked about the masseter, which helps to raise your mandible. The temporalis we talked about earlier also helps to raise your mandible along with the medial pterygoid muscle. This is your temporalis and your masseter, your medial pterygoid. All of those help to, when they contract, to raise your mandible. There are 4 muscles that depress your mandible. So when you need to open your mouth, the lateral pterygoid muscle, this is the lateral pterygoid here, the mylohyoid, which forms the muscular floor of your mouth. I'll show you that in a minute. The geniohyoid, and the anterior belly of the digastric. So if we were to look under your mandible, this is your geniohyoid, the anterior belly of the digastric, and the mylohyoid muscle. And as we get older, we would all love for those to stay very firm. These muscles are attached, and if you look at their name, to the hyoid bone. So the geniohyoid and the mylohyoid are attached to the hyoid bone. So it is though we're looking under the mandible, yes, up. Do you remember back in the phonatory chapters, we talked about the extrinsic muscles of the larynx, the suprahyoid muscles? Those are, if we looked at them individually, we just called them suprahyoid before. They're the mylo, the genio, and the anterior belly of the digastric, in addition to the stylohyoid and the posterior belly. All of those are responsible for, one, suspending your hyoid bone, and your hyoid bone suspends your larynx, but they all help to depress your mandible. Mylo, anterior, posterior belly of the digastric, stylo, and your hyoid bone. So these are all your superior suprahyoid bones that help not only to depress your mandible, but to help to strap your larynx into place. Your infrahyoids are at the bottom. Before we just called them the infra, but specifically this is your thyrohyoid. So it would originate from your thyroid cartilage into your hyoid bone. And your sternohyoid, which would originate from your sternum into your hyoid. Your omohyoid is the superior belly of the digastric. Let me say this, folks. You will, with regard to the the specific infra and suprahyoid muscles, I am going to ask you to tell me what they do, not to necessarily identify them individually. Questions? Questions about the anatomy before we move on to the physiology? I know it's a lot, but if you can remember that most of the names are associated with where they're located, where they originate, and where they insert. If you found that the models helped you, then I'm not suggesting that you make a model, but I am suggesting that you draw the different muscles. And it doesn't matter about how artistic you are, but as long as you know what you've drawn and you've placed it in the correct area, then that may help you study. Okay. Do you want to break or go ahead? Okay. Sure. For those of you who may have come in late, next week, when you logged in to Blackboard Collaborate, beneath it you may have noticed that there was a link to Zoom Virtual Classroom. That is the platform that we will be using after tonight. The Distance Education Office has assured me that they can download this recording and upload it into the content area where your other recordings are now located. We're not sure when Blackboard Collaborate, the university, decided to switch platforms. The Zoom platform is very easy to use and will also have recordings. So next week, there will be a link for you to join the platform Zoom for anatomy and physiology of the ear. eLearn stays the same, yes. Oh, they would have been a riot if they changed that in the middle of the semester. Okay, great. All right. Okay, this chapter talks about swallowing and articulation. Because we use our vocal tract, normally our oral and pharyngeal cavities, to swallow. And so many of the muscles that we use for speech production, we use to participate in deglutition, which is another term for swallowing. So swallowing involves our lips, our tongue, our velopharynx, we need that to be closed. our mandible, our oral pharynx area, our hypo or laryngeal pharynx. We need our epiglottis to cover our larynx, and so that the food will enter, or the bolus or the liquid will enter the esophagus and not our trachea. In graduate school, not only will you have a more in-depth class in anatomy and physiology and speech science, but you'll have a class in abnormal deglutition, which is called dysphagia or dysphagia, depending on who you're talking to. For the purpose of this class, all you will need to know with regard to swallowing are the 3 phases of deglutition. The first phase is very voluntary. We all are excited about the first phase. That's when we bite into that pizza, and we're going to call the lump of food as it's being chewed bolus. Okay, so the bolus is collected within the oral cavity, and your tongue helps to push the bolus back towards your oral pharyngeal area. And so your tongue is arching against your hard and soft palate to move the bolus of food into just at the beginning of the oral pharyngeal cavity. That is oral phase. The pharyngeal phase, your tongue continues to push the bolus of food back. The bolus of food drops into your hypopharyngeal cavity or laryngopharyngeal cavity. Your epiglottis folds over, closes off your larynx and your trachea, and allows the bolus of food to move into the entrance of your esophagus. That is the pharyngeal phase of deglutition. The esophageal phase, the bolus is carried into the pharyngoesophageal sphincter and further into the gastroesophageal sphincter. And at that point, you have peristaltic contractions that progress and cause the bolus of food to flow along the length of the esophagus before it enters your stomach. Now, as a speech-language pathologist, you will work with individuals who may not have a normal oral, pharyngeal, or esophageal phase of deglutition. Along with a radiologist, you'll look at films of a person swallowing different thicknesses of bolus and to determine if the flow of the bolus is normal, whether it residue or it gets stuck right on top of the esophagus. And so you will be working first to help diagnose dysphagia and then to determine what thickness of bolus or food is safe for that person to eat without the bolus of food entering the trachea, without that person aspirating. And so often when a person has a cerebral vascular accident that affects the innervation to the muscles of swallowing, that person will have difficulty swallowing particularly thinner liquids and foods. And so as a speech pathologist and with a radiologist, you'll determine that this person must have this thickness of food in order for deglutition to function normally. You will also learn to feed that person or teach support personnel to feed individuals in long-term care facilities, for instance. So you may see an image and you will be asked to identify which phase of swallowing is being depicted. Questions? Okay. Back to speech production. Okay, so the vocal tract with regard to speech. So the vocal tract has two functions with regard to speech. It serves as a filter for the source spectrum for vowels and for the flow of noise and possible the source spectrum for consonants. The second function is that velopharyngeal competence. We need the nasal cavity to be filled off when we're not producing a nasal consonant or a nasalized vowel. So those are the two functions of the vocal tract with regard to speech. Questions? Okay, so that second function of the vocal tract with regard to speech is velopharyngeal closure. So this again is your velopharyngeal port, and we need for those muscles of the velum that elevate the velum to work properly in order to close off the port so that the source spectrum will flow only into the oral cavity for all sounds that are not nasalized. So let's talk about how all of the articulators we talked about in the last chapter, what their functions are. So most of the things we've talked about in terms of vowels, we've talked about vowels as a segment of speech. It's just one speech sound in the midst of others that are strung together to form a word. So a segmental feature of speech are the perceptual elements that allow us to identify individual speech sounds. So a segmental aspect of the word cat would be k-at. There are three segments. And your articulators are placed in different parts of your oral cavity and your pharyngeal cavity in order for k to be produced, a to be produced, and t to be produced. Now we also produce suprasegmental features. Supra means above, so placed on top of segmental features, we may change the pitch of cat by meaning cat, or the loudness of cat, k-at. And so I placed the suprasegmental feature on T, I made it louder, or the duration, cat. Remember we talked about that as not only suprasegmental features, but temporal aspects of speech. And back in the respiratory chapter, we talked about needing more volume of air in order to apply or change the pitch, the loudness, or the duration of speech. So we need more volumes of air to apply suprasegmental elements of speech onto typically phrases, words, and sentences. We usually apply it to more than just one segment, more than just one speech sound. Questions about segmental features versus suprasegmental features. All right, does this look familiar? We talked about before the lungs being our air supply, our airstream that vibrates our vocal folds. The vocal folds then produce the fundamental frequency, which would be have the highest amplitude and the lowest frequency, and the harmonics that are multiples of the fundamental frequency. This source spectrum of sound now flows through the pharynx into the oral cavity if it is a non-nasalized sound. If it's a nasalized sound, from the pharynx into the nasal cavity. Now, depending on where our articulators are placed will depend upon what speech segment is produced. Before, we talked about formants of speech, which are clusters of speech of acoustical energy that are formed by changes in our mouth opening, in the width of our oral cavity, and whether our tongue is placed to the front of the oral cavity or to the back. That will change where these clusters of energy are concentrated. So if this sound flows through the vocal tract with our articulators forming these frequencies, these formants at these frequencies, then this is the sound that will be produced, and this is the ah. This is a good video for you to watch. Okay, so the vocal tract serves as a resonance filter. And so it tunes the source spectrum, accentuating some frequencies, decreasing the amplitude of other frequencies. For vowels. For consonants, it involves creating some type of noise within the oral cavity, whether the noise is friction or a burst of air will determine what consonant sounds are being made. Nasal sounds, our velum is lowered, and we're able to produce the sound. And so our vocal tract functions as a resonator. Okay, thank you, Susan. Susan, do me a favor, and let me see, because it may be on my, let me see if I have it here at home. Okay. Do me a favor. Let's see. Hold on. Yeah. Susan, if you would email me, what I will do, I probably have this PowerPoint in PowerPoint on my computer at work, and I will email it to everyone. Because definitely I will forget before I get back to work on Wednesday. Thank you for letting me know that. Okay, this is the source spectrum. For some of you, for the lab you just finished, either you looked at a line spectrogram like this or a continuous spectrogram. This would be the fundamental frequency is the lowest. It has the greatest amplitude. This is produced by your vocal folds. Okay, so your vocal tract in the neutral position would be the first formant is depending on your mouth opening, how wide it is. That's really not a good. The second formant is dependent upon the width of your oral cavity. And the third formant is dependent upon whether your tongue is to the front or back. And if this spectrum of sound generated by your vocal folds flow through your vocal tract with your mouth in a neutral position, so you just let your mouth relax, your lips relax, your oral cavity is wide, your tongue is to the back. This is the spectrogram of your production. And this is the schwa sound, or the ah. So if you say ah, your mouth opening is wide, correct. Your tongue is to the back, and so your oral cavity is wide. And for the third formant, your tongue is to the back. So your first formant is dependent upon your articulators, your lips, whether you're looking at it in a block diagram or here, and it will depend on if it is narrow. This first formant is lower in frequency. Why is this so wide? If the mouth opening is wider, then notice the first formant raises or increases in frequency. So this is the E sound, ah sound, and oo. So oo, our lips are together. Our first formant is lower in frequency. And this is just for the production of vowels. So the difference in the production of E, ah, oo has to do with the first formant, whether your mouth is open, wide, or narrow, or your lips are close together or apart. Now, all of these things happen simultaneously. So first, second, and third is not an order. Okay, all of this all of your articulators are placed into a position, and it is occurring simultaneously as sound is flowing through and being filtered. So the second cluster of energy or formant is dependent upon whether your oral cavity is wide or very narrow. If it is wide, such as the ah, the second formant is lower in frequency, closer to 1,000 hertz. If your oral cavity is narrow, such as for the E, the second formant filters the source spectrum, creating a cluster of energy around 2,300 hertz. So just by widening our mouths or narrowing our oral cavity can change the spectral characteristics of the sound source, creating the production of a different vowel. Okay, are you on a different slide? You're on this continuous. Hold on just a second. We'll get there in a second.
No, I'm on the slide number 15, I think it is. The second formant. So there's two. No, the one you were just on. Yeah.
This
so
one?
where it says
Father. Oh, and ah.
Father. How many on that particular? That spectrogram. How many formants are there in that spectrogram? You've got an arrow pointing at the second peak. Is that the second formant, and the peak before it, which is the highest peak, is that the first formant, and then it dips and then comes up to another peak? Is that the third formant? Just to make sure.
So you're reading. So you're reading on the line spectrogram from left to right. First, second, third formant.
So each of those two spectrograms, both the one that says ah as in father and e as in heed, each of those has 3 formants that were, and you circled the second formant for both of those.
Yes,
okay.
And we're, okay. And so when we are talking about a wider mouth, a wider oral cavity, then it's dependent on our mandible depressors to pull our mandible down, and our tongue muscle, the styloglossus, to pull it. No, it's not the styloglossus. It would be the vertical fibers, actually to flatten it out in order to produce this very wide oral cavity. And the second formant, therefore, is lower in frequency. But when the mandible is raised and the tongue is pulled forward, the second formant, or the original source spectrum, the cluster of energy for the second formant occurs at 2,300 hertz, and that helps to produce the E. So when a speech-language pathologist is helping a person say the correct speech sound, it is all based on physics. So if I'm helping a person say the E correctly, and let's say they were saying ooh instead of E, I'm going to ask them to, their mouth opening is going to be narrow, just like with the ooh, but I need the tongue to be forward and narrowing the oral cavity. I need, which will then widen the pharynx. And that will create the E as opposed to whatever the misarticulated sound is. So in other words, there is science behind how each sound is produced. And so therefore, when an SLP is intervening or providing therapy and asking the patient to place their articulators in a certain position, it is all based on physics.
I have a quick question just as a follow-up. So looking at the first spectrogram again on the same slide, as in father. Now, is that spectrogram representing the word father, or is it just representing so it's representing and then the second, as somebody is saying it's obviously there's different frequencies in that pronunciation, or in the vocalization of that.
Right.
And so the second, there's different formants when somebody's saying right? They're not saying the word father, they're just saying and
right.
There's certain formants. Okay.
Right. So when you see a line spectrogram, it's really only to depict one sound. And so they just put father there so you know that is the like in father. And E, which phonetically is represented by a lowercase I, it's pronounced E as in heed. And so in order for a person to produce the difference between an and an E, then their articulators must be placed in the correct position for this formant information to be produced. And that's all dependent upon the width of the mouth opening, the width of the oral cavity, and whether the tongue is to the back or to the front. All of this happening simultaneously in order to produce a different vowel. So it's like playing a musical instrument. These are the key, so if you're playing a trumpet or a woodwind instrument, these are the keys you must press in order to produce this note. And so your articulators are like those keys. These are where you must place your articulators in order to produce not a note, but a vowel.
Why does one vowel or one sound have multiple formants? So if somebody has a steady voice and they're able to say and it's not changing it at all, wouldn't the frequency just kind of be a flat line? Or is it because our voice is kind of always trying to find the right articulation of that vowel, that's what causes the differences in the formants?
Okay. So when you said we heard all of these frequencies.
Right.
All at the same time.
Oh, so they're simultaneous.
It's simultaneous. It's like you're playing a note. So if we were to record, so this is us recording, right? The production. And so when you say that includes all of these frequencies. But there are three areas where the amplitude is greater, or the clusters of energy. And we're calling those formants. And those are dependent upon where you've placed the keys or where you've placed your articulators. So if you were to say, and you guys are going to do a lab where you're going to produce a vowel, and you're going to produce a spectrogram, and you're going to identify the formants in that recording. And so it's not as though you're playing three notes. You're positioning three different keys in order to produce one note. Does that make sense? the spectrum, the spectrogram depicts the spectrum of sound. So we're looking at two spectrograms. But the source spectrum that is originally produced, or the sound that's produced at the by your larynx, is here. Okay? And the source spectrum is being depicted on a spectrogram. So a spectrogram is just a method of depicting acoustical measurements of the production of speech.
Is it, so I play guitar, and let's say you're playing a G chord, and a simple G chord, and basically you're holding down three strings, so there's three notes that form that one G chord. So is that a good example or analogy?
That is the example.
Each of those notes within that G chord would be a formant in this analogy.
Yes.
Okay.
Yes. And each of those notes for that G chord represent different frequencies, correct?
Yes, definitely. Yes, they do.
Okay. So you've got three different frequencies that have been accentuated in amplitude, and you're producing it at the same time. And the output is the G. Did anyone else play an instrument? It's really interesting. The more I teach this class, the fewer people that are getting that exposure at school. And so, for instance, so Susan, you played, okay. I played the flute, the piccolo, and the piano. So with the flute, not only did you have to place your fingers and press the keys for a particular note, you had to determine how tight your lips were also. So all of those things created different frequencies or different complex periodic sounds to make one note. Yes, correct. Now the last key, or the last formant that will produce that cluster of energy that's happening, is as a result of either constricting that source spectrum when it enters the oral cavity from the pharynx. Either we're going to constrict it with our tongue placed to the back, or we're going to constrict it with our tongue placed to the front. So with all of those adjustments of our articulators will depend on how we produce, or what vowel is being produced. So for instance, the C is a high front vowel. Your lips are not rounded, the tongue is to the front, C, and your first formant is lower because your mouth is narrow. Your second formant is higher because your oral cavity is narrow. And your third formant is higher because your tongue is constricting the sound to the front or near your alveolar ridge. A low back vowel. How many of you have already had phonetics? Okay. All right, Lauren. A low back vowel, your tongue is placed to the back, constricting the source spectrum. Your oral cavity is wider, your mouth opening is wider, and the clusters of energy are different now and are occurring at different frequencies. With the constriction to the back, your third foramen is lower with a wider mouth opening. Your second foramen is lower in frequency. However, with a wider mouth opening, the peak for your first foramen is now higher in frequency. And this is all dependent upon the position of your mandible, the position of your tongue, the width of your pharynx. The first three, the frequencies that we use for speech begin at your fundamental frequency and end around 4,000 hertz. Those changes within that frequency range determines our perception of those individual speech sounds. Now, you're going to see spectrograms that have more formants, but those are not necessary for us to be able to perceive the acoustical difference between each speech sound. So for speech production of a vowel, we're looking at the first three formants, usually up to about 30 to 3,300 hertz. Did that answer your question? I think. Okay. So if your tongue is to the back but high, you're producing the oo. So the dorsum of your tongue is raised. Your orbicularis oris is protruded for the oo. Your mandible is raised. And this is the difference in the spectral frequency range for the production of the oo.
Can I ask you a question? Sorry about that last.
Sure.
And I guess this applies to all of them. But would most people's spectrograms look somewhat similar for the oo, where you've got the high peak, then you've got a slightly lower peak, and then you've got a very small peak at the end? Does it vary from person to person or region to region in terms of dialect, or how universal is that?
It should look just about the same in terms of, and I'm sure there are standard deviations because it's going to depend on, remember, the fundamental frequency, right? So for a male, all of these may be shifted lower in frequency because his fundamental frequency is lower, right? So for a child, their fundamental frequency is higher, so their formants may shift a little bit higher than a male. It's not going to be extremely significant, but it should be within a range there. So that's if they're producing it normally. And typically when you're using a spectrogram to determine if someone is articulating a speech sound correctly, you're going to use a continuous spectrogram because it can record not only the vowels, but it can record the consonants. So this duh sound is here. This is the fundamental frequency. This is the first formant. Now we're looking at the frequency on the y-axis. This is the second, and this is the third. Remember, the formants are described with regard to striations. So let's say that you had a patient who, for the bead, produced it as bed. So you asked them to produce the word bead, and they produced bed. So now we can actually look at their acoustic information to figure out what they're doing wrong. And so for their oral cavity, let's start off for bead. Their mouth opening is narrow, so their first formant is lower in frequency than their recording of bed. Their oral cavity is too narrow, and their tongue is closer to the front and not the back. Why? Because we're looking at where the peaks of energy, the formant energy, is. So in other words, a speech pathologist can objectively determine why a person is articulating a sound incorrectly by measuring the acoustical parameters of that production. When you take, and this is one reason why I put this in PDF so that PowerPoint won't change my phonetic symbols. When you take phonetics, they will talk to you about this vowel quadrilateral, but let's see, hold on for a second. But there are, to answer your question, Bradley, there are tables that have the frequency in numerically that you should look for the first and second and third formant for each vowel. So instead of looking at a spectrogram, you can just print off the data numerically and compare it to a norm. Does that make sense? So let me ask you this question. Would you be able to identify the fundamental frequency, which will always be the darkest one, right? Because fundamental frequency is the lowest frequency a person can produce. It will always be at the bottom, and it will be the darkest. I will ask you to identify the first formant. The first formant should never be greater than 1,000 hertz. I will ask you to find the second formant. And I will ask you to find the third.
I have to say, without you doing this, in certain cases, I think it would be very difficult because sometimes especially well, now it's hard to see with your colored bars, but in certain cases they seem to really blend together. So it's hard to see the distinction between performance. So is there a better way for us to do that when we're looking at this?
Sure. There is a handout that gives you the numerical values of each formant for each vowel. So for instance, for the first formant, even if we looked back at a line spectrogram, the first formant peak is never beyond 1,000 hertz. This is the highest it goes. It's never beyond 1,000 hertz. So you wouldn't look for the first formant beyond 1,000 hertz. The second formant is never beyond 2,500 hertz. So it's between 1,000 and 2,500. This is the second. Actually, that one's kind of lower. So if we looked here, the first formant, the blue line, is never above 1,000 hertz. The red line, or the pink line, the second formant, is never above 2,500 hertz. And the third formant is really never below 2,300 hertz. Let's see if I got that pulled up. So back in the content area, there is a handout. Let me see if I can share that with you. Okay, are you able to see the handout? These are all the formats. I'm going to have to send this, let's see, E, U. So this should be an here. But these are the actual frequency data points that correspond here. And these are the changes that we've talked about that are made for each format. And so hopefully that will be of help to you. Okay, harmonics are the frequencies that are produced as multiples of the fundamental frequency. When those harmonics are filtered as they flow through the vocal tract, some of the harmonics will become clusters of greater energy. So if we looked at, let me get out of here. Okay, so if we go back to, okay, this is your fundamental frequency, and these are your harmonics. So those are the frequencies that are created when your vocal folds vibrate, okay? Now, these harmonics will be formed into clusters of three clusters of energy, which are called formants. So if you notice, some of the harmonics decrease in intensity or amplitude and some increase. And we're calling those clusters of energy. And those are formants. So formants are clusters of energy of harmonics. You're welcome. Okay. Now, we've talked a lot about vowels, but we also use consonants, right? And so consonants are not created based on resonance, right? They're based on really noise that's produced within the oral cavity. So a p or a t is called a stop because we're holding a burst of air and releasing it. And that's called a plosive p. and that's noise. That's an aperiodic sound. A fricative, we're causing friction as air blows through our teeth, like the S. That's aperiodic noise. If we produce a stop and a fricative, then that is called an affricate. And that is creating friction and creating a burst of air. And so consonants are made up of aperiodic sound. Now, some consonants we vocalize, we vibrate our vocal folds. So p would just be a burst of air, but b would be a burst of air and our vocal folds vibrating. So all consonants produce some type of noise, whether it's turbulent noise or a burst of air. However, all consonants may not be produced with our vocal folds vibrating. The only time we use resonance with a consonant is when we're attempting to produce a nasal sound. And so our velopharyngeal port is open, that source spectrum is allowed to go through the nasal cavity, which creates a murmur, kind of a resonance murmur, and that's how you get that. But the rest of consonants are not produced because of resonance. It's produced because of the introduction and production of noise. I will not ask you to identify a consonant on a spectrogram, but this is the way a burst of air would look, p and d. And this would be friction, very high frequency, see up around 6,000 hertz. And the vertical striations represent the noise, the sh and the s. Now the difference between the sh and the z is whether we're vibrating our vocal folds or not. So with the b, our vocal folds are vibrating, which means it's a voiced consonant, or with the, with the d and the b are all voiced, but with the p, the vocal folds aren't vibrating, and we call those unvoiced consonants. So, simultaneously, when we're producing consonants, we're creating noise. Yes, you can test it by feeling your thyroid, actually gland, and so if you produce the sound, that's friction. That's an aperiodic sound, but your vocal folds aren't vibrating. But if you produce that same friction and vocalize and vibrate your vocal folds, it becomes the z sound. And so for consonants, the key is producing noise alone or producing noise and a periodic sound by vibrating your vocal folds. So either it's just an aperiodic sound like s, or a periodic and aperiodic sound produced simultaneously for the z sound. I'm not going to go over voice. I'm not going to do that either. Okay, so let's take a look at this. For vowels, our vocal folds are vibrating, and the difference occurs in our vocal tract because of resonation. For consonants, stops, fricatives, and affricates, the p, the s, and the sh, and the ch, we're not vibrating our vocal folds, we're just creating noise. But if we want to combine them, create noise, and vocalize or vibrate our vocal folds, then we're producing the b and the g, z, and the v. And so they're voiced fricatives, voice stops, and the j, which is a voiced affricate. Sound generated, okay, so folks, let me go back here. We don't speak in single sounds, right? We speak in words. And when one sound is next to another sound, it can change the way that segment sounds, and that's called co-articulation. So in this example, we have the h sound and the p at the end, right? The H and the P. But depending on which vowel we put in between will depend on how it sounds. Heap, hop, hoop. The same H and the P, but we're just changing the vowel. And that's called co-articulation. And if you notice, the heap, your lips are spread wide for the H. But for hoop, because of the oo, the H is produced with your lips puckered, and that's called co-articulation. So just be familiar with this definition, and we've talked about the difference between segmental and suprasegmental features. Okay. Sound is generated by the larynx and filtered within the vocal tract. What is that called? What have we said that was? What type of theory is that? 1, 2, or 3? Anybody? Three, sound source. Thanks. Peristaltic contractions along the length of the esophagus occurs in which phase? What's the key word there? Great. Keyword was esophagus. The ability to seal off the nasal cavity is what? Two. Great. Velopharyngeal competence. Prosodic feature of speech, or suprasegment features of speech. Prosodic and suprasegmental is the same thing. Which is a prosodic feature of speech is suprasegmental. Same thing. Okay, folks, questions. No questions? Okay. Yes, you are. You're doing 2. 1 for each sound. You're welcome. So for this exam, you'll have labeling again of the anatomical parts that we talked about, the ones that, you know, like the mandible parts or the infra and supra hyoid muscles, you'll not be asked to identify those. And then you'll asked to identify the different phases of deglutition and to identify the 3 formants of vowels. So all the information in PowerPoint you should use it like a study guide. So with the lab, you're producing, and I would highly suggest that you use a continuous spectrogram and produce 2 different vowels, and you're going to identify the 3 formants and submit those. For those of you who could not print, you can always take a screenshot by using the key ALT, the Alt key. Hold it down and press the print screen. That will take a picture of your screen. Then paste it onto a Word document, save it, and upload it.